Так, или чем-то этим. Good day, dear students. Today's lecture is about anemic syndrome or anemia. So I'll try to explain you what is anemic syndrome at all and what is management of patients with anemia. So I think that you remember about developing of red blood cells, and it has very difficult maybe for understanding mechanisms, but in general we must only remember when we see the patient with any anemic syndrome that because different organs take place in erythrocyte metabolism, we need to differentiate the main mechanisms why there can be any disorders of hematopoiesis of red blood cells. So you will see that blood, bone marrow, and spleen, and intestine, and kidneys, a lot of organs take place in hematopoiesis and formation of erythrocytes. That's why pathogenesis of anemic syndrome can be very different. So what is anemia in general? Anemia is a decrease in number of red blood cells, which results in decreased oxygen capacity, carrying capacity. So we say about anemia when we see decreased levels of erythrocytes and hemoglobin. The result of it, of course, deficiency of oxygen in tissues. So what are the main mechanisms of anemia? We know a few of them. They can be also differ from each other, but in general we divide all mechanisms for three main. It's blood loss, acute or chronic hemorrhage, for example, deficiency of erythropoiesis, or excessive hemolysis because of red blood cells destruction. So when we must think about anemia if patient come to you with different complaints. So in men, we should think about possible anemic syndrome when we see a decrease of hemoglobin less than 14 gram per deciliter or 140 gram per liter, decreased hematocrit less than 42%, or a decrease of amount of red blood cells less than 4.5. And in women, the same markers will show you presence of anemia, and the lower border of these data are less. So in female, we think about anemic syndrome in case of decreasing of hemoglobin level less than 120, hematocrit level less than 37%, or red blood count less than 4. What I want you to remember from this lecture, the main principle how to treat anemia. So anemia in most cases it's not a main diagnosis. Anemia is a syndrome. That's why you must investigate patient and find the reason of accompanied anemia. And if you know the cause of anemia, so you treat the cause. Of course, if it's severe anemia, you will prescribe replacement therapy to increase level of hemoglobin and erythrocytes. But in general, you can't treat anemia, know nothing about or doesn't understanding the main reason, the main cause of anemia. That's why remember that anemia is a manifestation of underlying disorder. So try to find this underlying disorder investigate the patient, and then treat. One more time about main mechanisms of pathogenetic and etiological factors which lead to anemia in our patients. So, as I said, the most often reason is blood loss. It can be as acute as chronic. So you see that the most often acute hemorrhage is from GIT after different injuries in childbirth, or any surgical intervention. Chronic blood loss we may see in some tumors or cancer of GIT, also in heavy menstrual bleeding. In a time we'll see deficiency of iron, for example. In kidney tumors, when we see decreased erythropoiesis, and as a result of it, or maybe hematuria. So there will be a combination of pathogenetic mechanisms. So, and very often reason is ulceration of stomach or small intestine, and also not intensive but prolonged and or chronic maybe blood loss. Another mechanism is deficiency of erythropoiesis. In different variants can be different features in different variants of pathogenesis, can be different clinical signs which help you to differentiate anemic syndrome or anemia in general in different situations. So if there are problems with erythropoiesis, so anemia can be microcytic. So we may see it in iron deficiency, in iron transport deficiency, in iron utilization defect, iron reutilization defect, in some congenital anomalies like thalassemia, for example. And in some situation, it can be due to aplastic anemia, but in this form of anemia, we see already normal sizes of erythrocytes, and we call it as normochromic and normocytic. So in aplastic anemia, we see that there is normal color index and normal sizes of erythrocytes. In hyperproliferation, in chronic kidney diseases, in some endocrine pathology like failure of thyroid glands or pituitary, in protein depletion, in myelodysplasia and myelophthisis. And some anemias can be macrocytic. So when we see enlarged erythrocytes, and there are few anemias, which the main mechanism of which is decreased erythropoiesis due to deficiency of copper or folate and vitamin B12 and C. So in this situation, we see disturbance of erythropoiesis, and erythrocytes can be present in different sizes. They can be smaller, they can have normal sizes, and they can be enlarged. Another mechanism of anemia, it's excessive hemolysis. It also can be due to different factors. So what is excessive hemolysis due to intrinsic RBC defects? We may see it in hyperactivity of reticular endothelial system of spleen. In some diseases, when we see splenomegaly, and we call it as hypersplenism, we may see excessive hemolysis in some immunological anomalies. For example, autoimmune hemolysis, called antibody hemolysis, warm antibody hemolysis. So different variants of autoimmune reaction to our own blood cells. We may see some excessive hemolysis in mechanical injury, in infection, in traumas. Also, we divide excessive hemolysis or anemia due to excessive hemolysis due to intrinsic factors. For example, some membrane alteration, acquired membrane alteration like hypophosphatemia, paroxysmal nocturnal hemoglobinuria, or somatocytosis. In some congenital membrane alterations, so it's elliptocytosis or spherocytosis. In some metabolic disorders, which also may provoke excessive hemolysis. And there are some hemoglobinopathies which also lead to excessive hemolysis, so it's defects of hemoglobin structure. So it can be a hemoglobin C disease, hemoglobin E, C, and C, so thalassemia and sickle cell disease, which lead to excessive destruction of erythrocytes due to abnormalities of its of structure of hemoglobin. So knowing these main mechanisms of anemia, we may divide all anemias also in three main forms due to etiopathogenetic mechanisms. So it can be post-hemorrhagic anemia due to acute or chronic hemorrhage. It can be impaired RBC production due to deficiencies of vitamins or other deficiencies of iron, for example. It can be in aplastic anemia or these erythropoietic reasons. And it can be due to increased RBC destruction. So about destruction, I told you a few minutes ago. So reasons can be also hereditary or acquired. So what should we do with the patient in which we think about possible anemic syndrome? When he came to you as for the doctor and asked for your help. So very important to take carefully history and family analysis, because we said that reasons can be different as acquired as hereditary. You make also properly physical examination, and of course laboratory tests will help us to differentiate different forms of anemia. So what tests we should perform? Laboratory tests. It's common blood test with white blood cells and platelets also, because in aplastic anemia we will see not only deficiency of erythrocytes or decreased level of erythrocytes, but also decreased amount of other blood cells. We should check red blood cells indexes and morphology, because we said that some anemias are hyperchromic, some are hyperchromic or microcytic or microcytic, so different variants. We should understand the regeneration of red blood cells and use reticulocyte account to understand if anemia is hyperregenerative or hyperregenerative or normal regenerative. In some cases, we should perform a bone marrow aspiration and biopsy and peripheral smear to understand possible pathogenetic or etiological differences between different forms of anemic syndrome. There are some risk factors for anemia about which you should remember when you examine the patient. So, as I said before, it is very important to make history and family analysis carefully. So, you ask the patient about his diet. Maybe he is vegan, and in this group of patients we see deficiency of vitamin B12 and deficiency of iron more often. Maybe a patient has alcohol abuse, and in this group of patients we may see a deficiency of folic acid and folate deficiency anemia. In some patients, we may see hemolysis due to prolonged intake of some drugs or as a result of some chronic infections. And a very big group of patients with anemia, it's patients with cancer, with some hematological disorders, and some chronic inflammatory diseases. So we, in this group of patients, the main mechanism of anemia is suppressed red cell production. So to remember about reticulocyte count, I want you to see this picture and how we, in general, how we count the percentage of reticulocytes and what reticular count, what information give us the data of reticulocyte count. So it informs us about the response of bone marrow for etiological factor or for our treatment. So it's necessary to understand if bone marrow is still normally functioning. And it is useful for differentiation between different erythropoiesis and excessive hemolysis anemias. So this laboratory data is quite important to for differentiation of different variants of anemic syndrome. What we may see in bone marrow, what changes we may see in bone marrow due to aspiration and biopsy. So what are the indications for it? If all previous methods was not enough to differentiate or to detect anemia, the form of anemia, so we will use this test to understand possible problems with RBC, with erythropoiesis of red blood, hematopoiesis of red blood counts, cells. So if we can't understand the main reason of anemia, so unexplained anemia, it's indication for bone marrow biopsy. When we see more than one self-lineage abnormalities, so we see as anemic syndrome as, for example, thrombocytopenia or leukopenia. So we think about possible blood diseases, so like aplastic anemia, for example, or maybe some leukemias. Or we suspect primary bone marrow affection. So in such diseases like leukemia, as I said, multiple myeloma, in plastic anemia, as I said, or some myelodysplastic syndrome in other diseases, or metastatic disease, we may put this diagnosis using not only routine test, but very often we need to perform a bone marrow biopsy. And in such way, we detect the real reason of anemia in patient. So what are the main forms of anemia with which you will contact in your practice? It's anemia caused by iron deficiency due to blood loss, and anemia, so-called anemia of chronic disorders. It takes place in significant persistent infection, in chronic inflammation and malignancy. So these are two main anemias which you will see in your practice. And you must know how to manage the patient with these anemias. So these are the main characteristics of different anemias. As I said, due to iron deficiency, due to blood loss. So if it's acute, we see in common blood count that erythrocytes are normochromic and normocytic. This so they have normal color index and normal sizes. But there is polychromatophilia and some specific special features which also will help us to differentiate anemia caused by acute blood loss. So in severe cases can be nucleated red blood cells and left shifts of leukocytes leukocytosis and thrombocytosis. So it's some additional information which also can help you to differentiate acute anemia due to acute blood loss from, for example, anemia due to chronic blood loss. So in chronic iron deficiency anemia, we'll see microcytic or erythrocytes with anisocytosis and poikilocytosis, so different sizes and forms of erythrocytes. We'll see reticulocytopenia because of hyperregeneration, and hyperplastic marrow with delayed hemoglobination if we'll take aspiration of bone marrow. So what are the main or specific features of anemia caused by chronic blood loss? So we may see possible achorrhea. We may see smooth tongue and spoon nails as a manifestation of iron deficiency. We see absence of sustainable marrow iron, low serum iron concentration, and increased total iron binding capacity, and lower serum ferritin as a marker of depot of iron in organism. Iron deficiency leads to microcytic, also anemia with changed borders and sizes of erythrocytes, the same with reticulocytopenia, with the same changes in bone marrow, and also the same special features as in chronic blood loss anemia. So they are mostly the same, because chronic anemia caused by blood loss, the main mechanism of it's a deficiency of iron. So remember one more time the main characteristics of iron deficiency anemia. So another variant of anemia, it's folic acid deficiency, folate deficiency. So what we see, what morphological changes we'll see, that erythrocytes are oval, and macrocytes, so it's microcytic anemia. Also we see anisocytosis, reticular cytopenia because of low regeneration in bone marrow. Also hypersegmented white blood cells and megaloblastic marrow. How we will detect deficiency of folate? We may check the level of serum folate, and it will be decreased. We may try to check folate in RBC. And we may think about possible folate deficiency in some patient group, for example, in SPRU, patient who suffered by SPRU in pregnancy, in infancy, or in chronic alcoholism. So this is a group of risk for folate deficiency. Another another anemia caused by deficiency is vitamin B12 deficiency. So also it's very near in its laboratory manifestation with folate deficiency. So also oval microcytes will see, also anisocytosis, also poor regeneration with decreased level of reticulocytes, also hypersegmentation of white blood cells and megaloblastic marrow. And how we will detect vitamin B12 deficiency by check of serum B12. We may see frequent GIT problems and involvement of a central nervous system in B12 deficiency. Sometimes we may detect elevated serum bilirubin in these patients, or decreased lactate dehydrogenase. We may try to detect antibodies to intrinsic factor in serum in pernicious anemia, and sometimes absence of gastric intrinsic factor secretion, which provoke abnormal absorption of vitamin B12 and leads to deficiency of B12 in organism. So it's in special investigation also you may find such changes, clinical signs. What we'll see in hemolysis? In hemolysis, more often we see normochromic, normocytic erythrocytes with reticulocytosis, so increased regenerative properties of bone marrow. And in bone marrow we'll see erythroid hyperplasia. So as a special features of hemolytic anemia, we'll see increased serum indirect bilirubin and lactate dehydrogenase level, increased stool and urine urobilinogen because of metabolism of bilirubin in GIT, and hemoglobinuria can be present in fulminant cases of hemolysis and hemosideриnuria. What changes are typical for anemia caused by infection, cancer, or some chronic inflammation? So in this patient, we'll see normochromic, normocytic in early stages of disease, and in a time it can transform for microcytic. In bone marrow, we see normoblastic erythropoiesis, and there is no iron deficiency in general. So normal iron stores and level of ferritin is normal. So for some specific signs, we may see decreased level of iron, decreased total iron binding capacity, normal depot level of iron in organism, so normal serum ferritin, and normal iron marrow iron content. There are some abnormalities which lead to changes of structure or border of form of erythrocytes. So there are some rare diseases, but also you should remember about them to differentiate different forms of anemia in your patient. So hereditary spherocytosis, what are the characteristics of this form of anemia? So we see in CBC spheroidal microcytes. This anemia is normoblastic, and we see erythroid hyperplasia in bone marrow, and also there is normal regeneration of erythrocytes, so we see reticulocytosis. As a special features of this form of anemia, we'll see increased red blood cells hemoglobin level, increased RBC's osmotic fragility, so they are quite poor, these erythrocytes, for osmotic changes of osmotic pressure, and shortened survival of labeled red blood cells. Another anemia which also is congenital and has some specific signs, and it helps us to differentiate it from other more often forms of anemia. It's sickle cell anemia. So what we see in common blood tests: anisocytosis and poikilocytosis, different forms of erythrocytes, some sickle cells in peripheral smear we may see, sickling of red blood cells in preparation with hypoxia or hyperosmolar exposure, and also normal and good regeneration. There is reticulocytosis due to it. There are some specific features which also will help us to differentiate sickle cell anemia from other anemias which we discussed before. what there are some more rare forms of anemia. So we may see problems with red blood count in patients with marrow failure. So you see the main characteristic of bone marrow failure or bone marrow replacement in myelophthisis. So I think that you can make a copy of this picture and to use it in your practical classes. Now we'll continue with more often forms of anemias. So the same is for this picture. So you see the different reasons of etiological types of anemia, like cold agglutinin disease, paroxysmal nocturnal hemoglobinuria. You see what are the main features of these diseases, and also remember it to know that there are some rare but also rare forms of anemia, but also you should remember about them in your practice. So let's discuss iron deficiency anemia. So as I said, it's the most often form of anemia. Some main data about iron metabolism. So we see that total body iron, of course, is more in men than in female, but we should remember that deposition of iron in women is less. That's why the risk of further anemia is higher than in men. If there are some more predispositive factors. So iron is absorbed in duodenum and upper jejunum. So if patient has any chronic problems in GIT, upper part of GIT, in a time also it can disturb iron metabolism. Iron absorption is best from food. That's why all our drugs, of course, they are useful, they are necessary, but in general, the main iron, hem iron, which our organism is absorbed better, is meat iron. That's why when you treat the patient with anemia, you must give a general recommendation about diet. We should remember that iron, natural iron, is better absorbed in when there is the presence of vitamin C also. So if you want to improve absorption of iron, you need to prescribe some drugs containing also ascorbinic acid, or increase in diet products which are rich of vitamin C. You see that absorption is not very intensive. That's why the treatment of iron deficiency is very prolonged, because sometimes when it's severe deficiency of iron, we need a lot of time to normalize deposition of iron. Because our absorption is not very intensive, and loss in some cases is more intensive than absorption. So we see that iron is not only in hemoglobin. That's why when you treat anemia, you should remember that the main idea is not only to normalize level of hemoglobin. Another main target of our treatment is to improve depot of iron in organism, because iron is not only, as I said, in hemoglobin, it's in ferritin, it's in hemosiderin, it's in myoglobin, it is present in some tissue enzymes. So our organism needs iron not only for hemoglobin. So remember about it. So what are the main features of anemia caused by iron deficiency. So blood loss is the most often reason of iron deficiency anemia. It's more often we may see in frequent cause in some chronic occult bleeding with no clear clinical signs of bleeding. We may see also it in premenopausal women with cumulative menstrual blood loss. So when this is a group of risk for anemia, and you should monitor level not only of hemoglobin but of serum ferrit, iron and ferritin level in these patients. So also we may see chronic anemia due to chronic intravascular hemolysis and vitamin C deficiency, which, as I said, is a very important component of iron absorption, and vitamin C deficiency also can manifestate with capillary fragility, hemolysis, and sometimes bleeding. Also, we may see iron deficiency anemia in case of increased iron requirement. So, adolescents and children aged 2 years or during pregnancy, our organism needs more iron. So, this is also a group of risk for further anemic syndrome. That's why good diet, increased amount of iron in nutrition. And in some cases, we may see deficiency because of decreased iron absorption. So it's a patient with gastrectomy due to different reasons, and some problems with the small bowel absorption. There are some chronic diseases like sprue, as I said before, for example, celiac disease, when we see changes or disorders of absorption of iron and also some other nutritions, and it manifests later with anemic syndrome. So how we may detect deficiency of iron in organism. So we, of course, make common blood count and see some specific signs about which I said before. So we check serum iron. We should check iron binding capacity, serum ferritin, transferrin saturation, reticulocyte count, red cell contribution, whites, and peripheral blood smear sometimes, and bone marrow examination, rare in some not clear cases. So these laboratory markers will help you to differentiate different variants of anemia and prove or exclude iron deficiency in organism. So you see the main markers and their normal borders to understand if patient, man or female, has deficiency of iron in organism or no. So remember these borders to understand and to use them also in your practical classes and in your practice in general. So what I want you also to remember, that anemia is not no, of course, we say about anemia when we see deficiency or decreased level of erythrocytes and hemoglobin. But in general, anemia starts before then we see changes in red blood count. So anemia has a few stages, and it become when we see the decreased level of ferritin. It's special, it's not routine test, of course, but if you examine the patient or from risk group, so you need to monitor not only count of red blood cells, but or hemoglobin, but you should check the level of serum ferritin, of transferrin, or levels transferrin, and you sometimes should start the treatment of anemia before patient has already deficiency of hemoglobin. So you see that we may divide iron deficiency anemia, pathogenesis of it, in for some stages. And you see what changes of what laboratory markers will be changed before we see classic decrease of hemoglobin level. So in general, we see that patient has anemia only in using our routine test, only when it's already stage 3 or 4 already or 5. So if it's severe deficiency of iron, and then we see already symptoms and signs of anemia. And you see that early markers of anemia we can't detect using only CBC. That's why if you monitor patients with risk factors, use another test more informative for early stages of anemia. So, one more time, in what other group risk for iron deficiency? So it's chronic blood loss, it's intensive menses, it's acute blood loss due to trauma, for example, it's blood donation or phlebotomy as a treatment for polycythemia vera, for example. So in this situation, you may see increased iron loss. Increased demand for iron and or hematopoiesis. So we see it what patients are in risk group. It's rapid growth in infancy or adolescence, it's pregnancy, and sometimes erythropoietin therapy in patients with chronic kidney diseases. When we see decreased iron intake, absorption, or use, in vegans, for example, in inadequate diet, in malabsorption diseases like Crohn's disease or celiac sprue, in post-gastrectomic patients because of malabsorption caused by surgery. The main symptoms and signs of anemia are, so they are not specific, but in general, most patients with anemic syndrome has these symptoms and signs. So it's fatigue, it's loss of stamina, it's shortness of breath, weakness, dizziness, pallor, restless leg syndrome. So as you understand, these symptoms are so unclear and unspecific that you may think about any disease with such not clear manifestation. So when a patient comes to you with such diseases, I'm not sure that your first idea will be that patient suffers from anemia. But you should remember about this, because a lot of people ask for medical help. Patients with anemia, when already it's a severe anemia, and when we perform CBC plus these unspecific signs, of course, we'll see already severe deficiency of hemoglobin. There are also some so-called sideropathic syndrome, which manifestate with connective tissue dystrophy. You see changes of nails, for example, with dysphagia, with smell or taste disorders, with glossitis, cheilitis, and sometimes muscular and sphincter weaknesses. So in severe anemia also we may see such additional clinical signs which show us severe deficiency of severe hypoxia and severe deficiency of iron. So what are the main targets and what are the main principles of iron deficiency, treatment of patients with iron deficiency? As I said, all anemias has their cause. So if you don't know the cause, you never help the patient to stop his anemia. So iron therapy without knowing of main cause will give you poor result. That's why you need to exclude any variants of bleeding, because it's the most often reason of iron deficiency. You need to improve quantity of iron in diet and use some iron salts which are better absorbed. So you see what are the most often iron salts which we may use for the treatment of patients with iron deficiency. Better to use them perorally, not less than 30 minutes before meals. And of course, no drugs which decrease absorption. The typical initial dosage of iron is 60 milligrams of elemental iron. For example, it's if we say about ferrum sulfate, which very often form of iron salt which we use for treatment of iron deficiency anemia, it's near to 325 milligrams, which we give once a day or twice a day. It's depending on the possible side effects and necessity of intensive treatment. Parenteral iron cause the same therapeutic response as oral iron. So oral iron supplementation is better for human organism. It is more physiological, and there is no differences in absorption and clinical effect, but we see more side effects, adverse effects when we use parenteral iron. So you start the treatment of patients with iron deficiency using oral drugs. Only if you understand that there is poor absorption, or in general after gastrectomy, for example, and severe atrophy of stomach, or surgical intervention in small intestine. So when you understand that oral replacement therapy is ineffective, then you may use parenteral iron, because there are a lot of side effects, adverse effects, such as anaphylactoid reaction, like serum sickness, thrombophlebitis. So the main treatment is trying to increase iron and hemoglobin in general using oral drugs, oral iron. As I said, better oral iron is better absorbed with ascorbinic acid, with vitamin C. So if you prescribe oral iron, you need to prescribe additional ascorbinic acid, as in juice, for example, as in other variants, increasing ascorbinic acid in diet. If you understand that oral iron with vitamin C, it's a poor practice because of malabsorption, you should detect the dosage of parenteral iron with hematologists, with specialists in this field. You should remember that oral or parenteral iron therapy is not quick, because, as we said, we need not only to correct level of hemoglobin, but we need to replenish tissue stores of iron. It's very, very important to prevent further exacerbation of iron deficiency. So one more time, for treatment we use oral iron salts, ferrous sulfate, ferrous gluconate, ferrous fumarate, so different variants of iron salts. We give it near to 30 minutes before meals. We use the middle dosage of iron is 60 milligrams of elemental iron. If we try to increase the daily dosage of iron, we may provoke some adverse effects like constipation, for example, or sometimes pain in abdomen. So better to use less dosage but more prolonged than use big dosage and stop treatment because of adverse effect. And of course, we said that we need additional vitamin C to increase absorption of iron in GIT. One more time, parenteral iron is not has the same efficiency as oral iron, but parenteral prescription has very severe adverse effects with some complications sometimes. And the middle duration of oral or parenteral iron treatment or iron therapy is near to 6 months, sometimes more, to make iron depot full. Some words about anemia of chronic disease. So it's the next after simple iron deficiency anemia. We see that we may find this anemia in patients with different infections, chronic infections with chronic inflammatory process, for example, in rheumatoid arthritis, and in patients with cancer. And prolonged treatment from cancer. What are the pathophysiological mechanisms of anemia caused by chronic diseases? So we see shortened period of survival of erythrocytes' life due to some unknown mechanisms in patients with cancer or chronic granulomatous infection. We see that in this patient erythropoiesis is impaired because of deficiency of erythropoietin, disturbed bone marrow representatives of erythropoietin, and also we see intracellular iron metabolism, impaired intracellular iron metabolism in patients with different chronic diseases. So it's multiple pathogenesis, multifactorial pathogenetic mechanisms of anemia or in case of chronic diseases. Symptoms can be unspecific, and sometimes we see symptoms of main disease. It's more clear. What we see in CBC, so we should check the level of hemoglobin. It will usually more than 8 grams per deciliter. We also check the level of serum ferritin, and we see that it's mostly normal unless iron deficiency also is present. Sometimes we in a time will see deficiency of iron also. How we treat it? We treat the underlying disorder, so we need to treat the main disease. For the treatment of anemia in chronic diseases, we use as erythropoietin as iron supplements. Because, as we said, the first is disturbance of erythropoietin production and sensitivity of bone marrow to it, but in a time we may see also iron deficiency. That's why only treatment by erythropoietin will be not enough effective. That's why combinative treatment. The next form of anemia which take place in our patient, and you will see it in your practice, it's megaloblastic anemia. So what are the megaloblasts? Megaloblasts are large nuclear red blood cells, precursors with non-condensed chromatin. Megaloblastosis precedes macrocytic anemia. Microcytes are enlarged red blood cells, so they have increased borders, increased sizes. So in what situation we see megaloblastic anemia? More often it's deficiency of vitamin B12. We may find it in patients with inadequate diet, in vegan diet, in breastfeeding of infants by vegan mothers, and in fat diets. It can be due to impaired absorption. So, as we said, in autoimmune atrophic gastritis, in destruction of gastric mucosa after gastric surgery, we see deficiency of intrinsic factor, due to which extrinsic factor, which is B12, vitamin B12, can be normally absorbed. Also, we may see it because of inhibition of intrinsic factor, in decreased iron secretion, in also atrophic gastritis, in some small bowel disorders like inflammatory bowel disease, in Crohn's disease, for example, in celiac disease, in cancer, or biliary or pancreatic disorders which lead of atrophy sometimes, or disorders of malabsorption in small intestine, and in AIDS. Also, B12 deficiency can be due to inadequate utilization, enzyme deficiency, liver disorders, in transport protein abnormalities, in some situations with prolonged drug intake, for example, in prolonged intake of antacids, metformin for treatment of diabetes mellitus second type, and sometimes nitrous oxide, repeated exposure of it. Another mechanism of megaloblastic anemia is folate deficiency. Also, we may see it in vegans when diet is lacking fresh green vegetables or enriched grains, in chronic alcoholism, in total parenteral nutrition, in also celiac disease when we see disturbance of malabsorption in small intestine, and it's also in prolonged intake of some drugs which interact with folic acid in organism. In some anticonvulsants are sometimes some cytostatics like methotrexate, for example, in also treatment of diabetes mellitus by metformin, and some other drugs. So, pathophysiology of megaloblastic anemia. What we see? Megaloblastic states result from defective DNA synthesis. All cell lines has this dysbiosis. Dysbiosis results in intramedullary cell death, making erythropoiesis ineffective. And we see also, in case of deficiency of B12 and folate, reticulocytopenia, because this form of anemia is hyperregenerative. Also, decreased level of leukocytes and thrombocytes in a time. What are the clinical signs of megaloblastic anemia? So, more often we see pale icteric skin, peripheral neuropathy, and sometimes dementia due to disturbance of central nervous system, gray hair, hunter-glossitis. You see the picture, how it looks like, and sometimes diarrhea as a manifestation of GIT disorders. No, you see the macrocytes, megaloblasts, which we may see in blood smear in case of megaloblastic anemia and caused by B12 or folate deficiency. How we'll detect it? So we check the borders of the sizes of erythrocytes, so we perform CBC. We make bone marrow aspiration in unclear cases. We may check the level of folic acid and B12 in serum, because we know that more often a patient with different GIT problems has this form of anemia, so we should examine GIT very carefully. And we may check the level of food cobalamin malabsorption to understand if there are some problems with absorption of B12. In CBC, we will find macroovulocytosis, anisocytosis, and poikilocytosis also can take place. Whole jolly bodies, what is it? It's residual fragments of the nucleus, which we also very often see in CBC. As I said before, reticulocytopenia, because poor regeneration of bone, of erythrocytes in bone marrow, hypersegmentations of granulocytosis, sometimes neutropenia, which take place later due to also deficiency of B12 and folate, and thrombocytopenia also can be present in severe cases. Sometimes for differentiation and for detection of B12 deficiency, we use Schilling test. I think that you may also make a copy of this picture to understand what is it, what are the principles of this test, and how it can help us to differentiate, to detect B12 deficiency and the mechanism of it in patients with megaloblastic anemia. So how we'll treat megaloblastic anemia? As we said, in all cases, we treat the main disease. In all cases of anemia. So the next one is supplementary therapy. So if we see deficiency of B12, we prescribe it orally if we think that there is no problems with absorption, or we may use parenteral prescription if we think about possible malabsorption. You see the dosages of vitamin B and B12 and oral folate acid supplementation. Treatment is also prolonged and better to prevent formation of megaloblastic anemia. So also in group of risk, we may prescribe treatment as a prophylaxis in prophylactic dosages as B12 as folate. Another anemias, very big group, and hemolytic anemias. So I give you some main key maybe characteristics which help you to differentiate hemolytic anemia between each other and with another anemias. So one more time, what are the main mechanisms of hemolysis? It can be disorders of intrinsic disorders intrinsic to RBCs. So it's in hypersplenism we may see some immunological abnormalities, autoimmune hemolytic anemias. We may see hemolysis in some infections. You see what infection may lead to hemolysis in human organism due to some toxins also in infection. For example, Clostridium perfringens. In mechanical trauma, we may see also hemolysis, and for example, in thrombocytopenic purpura or hemolytic uremic syndrome, or sometimes in valvular heart diseases. Some toxins like copper or lead, or some insects venom or snake venom, we may see hemolysis. Some congenital RBC membrane disorders, like we said before, elliptocytosis or spherocytosis. In acquired RBC membrane disorders, in disorders of RBC metabolism, in deficiencies of glucose 6 phosphatase, some disorders of hemoglobin synthesis. We said about different hemoglobinopathies. So a lot of different reasons of hemolysis, and if you see hemolytic anemia, you need to detect the mechanism of its anemia. So hemolysis can be also acute as a blood loss and chronic. It can be prolonged or episodic. It can be extravascular and intravascular, and it can be present both in one patient. So different changes of morphology of RBC you see in these pictures: spherocytosis, thalassemia. So I think that's more pictures you'll see in practical classes when you will discuss anemic syndrome. So symptoms and signs of hemolysis. Systemic manifestation. So the same unspecific signs: pallor, fatigue, dizziness, and sometimes hypertension. If it's acute hemolysis and we see hemolytic crises, so it can be accompanied with chills, fever, pain in back or abdomen, sometimes shock in severe cases. We may see also splenomegaly and jaundice in severe hemolysis, and changes of urine color. It can become red or reddish brown due to hemoglobinuria. We should check the peripheral smear and reticulocyte count, serum bilirubin, lactate dehydrogenase, and ALT to detect different forms of hemolysis and hemolytic anemias. Sometimes we used to measure urine hemosiderin and serum haptoglobin to understand also the form of hemolysis. Sometimes we use RBC survival by using of radioactive label. Sometimes we use hemoglobin electrophoresis to understand the form of hemoglobinopathy. RBC's enzyme assay, flow cytometry can help us to differentiate different forms of hemolytic anemias, presence of cold agglutinins, or check the osmotic fragility of erythrocytes. So different laboratory instrumental tests will help us to differentiate diagnosis in hemolytic anemia. RBC's morphological changes in hemolytic anemia, which help you to differentiate hemolytic anemias from each other. So the main forms of anemia, changes in red blood cells, and the main causes which may be as a result of it. So also you may take the picture of this slide and use it for your practical classes and practice at all to understand what morphological changes and in what are maybe the causes of these morphological changed RBCs. What should we remember about treatment of hemolytic anemia? Treatment depends on the specific mechanism of hemolysis. So sometimes you need iron replacement therapy if it's hemoglobinuria and hemosideruria. So if patient suffers from hemolysis due to autoimmune reactions, so you need to control autoimmune process, and we may use steroids, and they can be helpful or useful as an additional treatment in warm antibody autoimmune hemolysis, for example. Sometimes we need to use chelation therapy, even if long-term transfusion therapy causes excessive iron accumulation to prevent hemosiderosis. In some patients, splenectomy can be effective when we see increased RBC destruction. So splenectomy will be useful in these forms of hemolysis. If patient has cold agglutinin disease and hemolysis due to it, we say the patient to kept warm to prevent these reactions due to cold. Some patient needs folate replacement and long-term hemolysis. So in hemolysis, you need to understand the main cause of it, and of course trying to interact with the etiological factor. And if it's need to prevent hemosiderosis, so chelation therapy, or if you see already some deficiencies, maybe you need to improve hematopoiesis by replacement therapy. Another anemia, which also about which also we need to remember, it's aplastic anemia. It's a rare form, but you need to differentiate it from other anemias and understand what to do with the patient and how to help him. True aplastic anemia is idiopathic, and we can't find the real reason of it. And it's about half of cases in aplastic anemia. Most common, we may see it in young adults and adolescents. Of course, there are some secondary aplastic anemias which take place in some toxins, interaction or with chemicals like benzene or inorganic arsenic, in radiation, in some drug intake, prolonged drug intake. And you see that in these drugs are quite often, which we use in our practice. So the real mechanism is still unknown, but you should remember that aplasia of bone marrow, and as a result of it, aplastic anemia, can be due to intake of some chemicals and some drugs. So pure RBC aplasia can be also acute and chronic. So in acute, you see erythroblastopenia is a breath and disappearance of red blood counts precursors in bone marrow. Sometimes it can be manifested after parvovirus infections, especially in children. The anemia lasts longer than acute infection, so after infection you may see prolonged anemia in children or adolescents. And it can be chronic. It can be associated with some hemolytic disorders, timomas, or autoimmune mechanisms, also intake of some drugs, and also it can be manifestation of sometimes of chronic lymphocytic leukemia. So you should remember that if you see aplastic anemia, think about leukemia also. So one more time about possible causes of aplastic anemia. So we may see in different autoimmune processes. It can be hereditary in half of cases. It can be in viral hepatitis and radiation exposure. It can be in some chemical poisoning or some drugs intake, prolonged drug intake. What are the criteria of aplastic anemia? So we see that in this case anemia has normochromic and normocytic characteristics. We see in common blood count that all blood cells is decreased, so it's pancytopenia, not only of erythrocytes. We see that these anemia are regeneratory, so very poor, very low count of reticulocytes. We see in this form of anemia that serum iron is decreased. We see if we make bone marrow aspiration and biopsy, we see lower cellularity in it. Trypano biopsy will help us to understand and see, and it shows the disappearance of red blood cells, red bone marrow. So the signs and symptoms of aplastic anemia also quite unspecific, and they are very varied due to severity of pancytopenia. Symptoms and signs of anemia usually are severe. We also see, because of deficiency of thrombocytes, petechia, hemosis, sometimes bleeding of from gums. We may see frequent infections, respiratory infections due to agranulocytosis. More often splenomegaly is absent unless induced by transfusion hemosiderosis. So splenomegaly is not typical for aplastic anemia. because sometimes we should differentiate splenomegaly and, or not splenomegaly, I mean hypersplenism and aplastic anemia. And symptoms of pure RBC aplasia are generally milder and relate to the degree of anemia or underlying disorder. How we may put diagnosis of aplastic anemia? Of course, routine tests like common blood count and reticulocyte count. As we said, there is poor, low pancytopenia and lower amount of reticulocytes, so decreased reticulocyte count. For this anemia, we should perform bone marrow examination, and aplastic anemia is suspected in patients, particularly young, as we said, with pancytopenia. Severe aplastic anemia is defined by bone marrow with less than 30% cellularity, hypercellularity, and the presence of two or more the following signs: absolute neutrophil count decreased, absolute reticulocyte decreased, and platelet count also decreased. So if you see anemia with decreased level of neutrophils, reticulocytes, and platelets, you must think about aplastic anemia and try to find the reason of it. How we treat aplastic anemia? So it's quite poor in treatment. We use hematopoietic stem cell transplantation. If transplantation is impossible, sometimes immunosuppression with equine anti-thymocytes, globulin, and cyclosporin can be used. I think that today's information will be enough for you for preparation for practical classes and for maybe for your further practice. Anemia is very difficult sometimes for learning, but I think that information which I trying to give you today will be necessary for you, and if you your discussion during our practical classes will give you more information and more details to understand the main pathogenetic mechanisms and the main algorithm, what we should do with the patient with anemic signs. So thank you for your attention. Good luck. Bye.